parenting intervention for women in treatment for substance use. And we are joined today by Meghan Gannon, who is an assistant professor at Thomas Jefferson University and a mindfulness-based parenting instructor at MATER with extensive mindfulness training. Her primary focus is research, working with pregnant and parenting women in substance use treatment to test interventions to improve attachment in the mother-child dyad. She also researches the impact of early exposure to trauma and lifetime vicarious trauma. So welcome, Meghan, today. We also have Diane, who is a professor of obstetrics and gynecology and pediatrics, the director of maternal addiction treatment, education and research division, or MATER, at Thomas Jefferson University. Her primary areas of research expertise are with underserved populations and include health behavior, change, implementation science, primary care practice change, evaluation and outcomes, behavioral epidemiology, and drug dependence treatment. Her primary research focus is on innovative interventions to enhance maternal and child health, and they are going to present today on MATER. And so I will welcome you and turn it over to you to start your presentation.
Thanks for your attendance today. Meghan and I are excited to be here. We've been meeting with Brittany, and her energy has really sparked us in some great conversations. And so we're really delighted, and I'm going to talk about MATER, and the program that was developed and how we're transforming MATER using mindfulness. And Meghan and I are going to share some of our research projects and our findings. Yeah, you can go to the next one, Meghan. So just some objectives, because we like to know where we're all starting together. We hope that we can define and comprehensively discuss what SUD treatment is at MATER that is formulated around the maternal-child dyad. We're going to help you understand the elements of comprehensive transformation that is exemplified by programmatic examples that we're going to share with you today. We have a lot of examples to share. We only pulled out some, but we'll try to mention others along the way. And we're going to be talking a lot about mindfulness practice, the use of non-judgment, compassionate, and present moment experience and awareness that actually goes to improve the communication with patients, patient outcomes, and decreases staff stress and burnout. And lastly, we hope that you come to understand how to apply mindfulness practice for stress reduction and grounding in present moment experience with patients. So when we talk about organizational transformation, which we've done at MATER, we're talking about some big, courageous kinds of leadership that shift the focus away from a traditional substance use treatment or drug addiction treatment to substance use treatment that is more compassionate. And the way in which we've done this is that we've decided to do rather than ask to do. And to be sort of radicals in what we do in terms of drug treatment, and not ask our funder or the university, but really show that doing things in alternative ways impacts patient treatment. So we increased democracy in the workplace. That was one of the things as director that I did, was create an executive team to make decisions rather than just the leader making decisions. And that really, if you look at MATER, we're a democratic feminist model. And we also use organic leaders, identify and use organic leaders in the organization. So if there are leaders that don't have leadership titles, they're still invited into discussions around policy and implementation and really anything that MATER does. And they could be, the organic leaders could be peer staff or not, but peer staff are invited to inform policy as well as to share their insights about patient engagement. We use mindfulness throughout the organization so that we can have really courageous conversations, because we know there are a lot of difficult feelings at work, especially doing this kind of work. And to be able to have courageous conversation shortcuts a lot of depleting energy. It also gives us a lot of ability to have more creative work and creative thinking. And I would say they both add to unbounded aspirations. So it's the kind of big vision that you walk out of work usually thinking, I wish it was this way. Well, that's the way we make it, is the way we wish it is. And then constantly to have these perceptual shifts, or as John Kabat-Zinn calls them, orthogonal perceptual shifts, which means the problem doesn't intimidate us. The problem actually becomes something that motivates us to do things differently with more excitement. Megan? So we do a lot of mindfulness activity, and I just wondered if you all wanted to do a little 2-minute meditation. I could lead us through one. So I'm going to ask for a show of hands. Would you like to do a mindfulness and see what our mindfulness is like? I see a hand. I see a thumbs up. Okay, I'll lead a brief meditation, which just help us understand what this is like. So the mindfulness meditation I'm going to lead right now is one that therapists can lead with patients. Nurses could lead. Childcare workers could lead with children, all in our organization. And it's the way we start off all of our leadership meetings. So if you first just realize that you're sitting in a chair, and notice where your body is making contact with the chair. Are any muscles stressed that you could relax because the chair is holding you? And then coming to your breath, breathing in through the nose and out through the nose or mouth. Just following the breath. Noticing where you feel the breath most prominently. The coolness on the upper lip, the back of the throat, the chest, or the stomach's movement. Following the breath for a few cycles as it comes in the body and leaves the body. No need to change the breath or judge the breath. Simply allowing. And as thoughts come and take us over, allowing the thoughts to pass like clouds in the sky. Perhaps imagining taking a pair of scissors and cutting the string of that thought, allowing it to float by. Allowing sound to be in the background and the breath in the foreground. Noticing any feelings that are coming up and allowing them to just be there. Feelings of enjoyment, feelings of exhaustion, feelings of joy, feelings of sadness, whatever is there, just accepting. Now coming back to the breath and taking a couple of deep inhales and let the exhale be a little bit longer than the inhale. And if there is a sound that comes out with the exhale, that's good too. And now, as you're ready, but very gently, if your eyes are closed, begin to open them and come back to the space. So, Megan, I wonder if we can go back to the gallery for a minute. So I wondered if anyone had any feedback. How did you feel before? How do you feel afterward? So just a little background about MATER. MATER is about 47 years old. It was founded by Loretta Finnegan, Dr. Finnegan, as you probably know, the Finnegan score and how we assess babies with neonatal abstinence syndrome. Loretta is still engaged with me. She and I are actually doing an ATOD presentation in April together. So we still see her and she's still involved in this work. We get extensive funding, grant funding, because we have a 4-person, soon to be 5-person faculty unit that does a lot of research in maternal addiction, but really in maternal child health, even outside of addiction. So we're funded by each of these sources that are listed here. We have comprehensive services at MATER, including the pharmacotherapy for OUD, mindfulness, a trauma-responsive group and individual therapy, assessment, treatment of psychiatric disorders, case management. We actually have care management as well, advocacy for legal issues, housing, financial and vocational needs. And then we'll talk about some additional medical clinical programs that we've put together for MATER. We have about 10 or 12 women that are admitted per month, although we work with approximately 18 to 20 women a month and get them care in other programs, as well as we're a center of excellence, our work is to get women treated in the most appropriate environment for them and geography. So sometimes women come to Philadelphia but really live in other states and want to go home, and so we make sure they're connected to treatment by the time they leave Thomas Jefferson Hospital. The average duration of treatment is 3 years for our patients. Next. So this is what it really looks like. It's the mother and child dyad. Now it's expanded to family, and Meghan and I are going to talk about that too. But this isn't all the services, but just to show that these services are surrounding the maternal-child pair. Next. So I'm not going to spend a lot of time on this slide. We all know that opioid use is an epidemic, and that we're seeing higher levels of women who are pregnant and more NAS, babies born with NAS, and these issues around unemployment, incarceration, comorbid physical, that should be, and mental conditions, and stress, and the stresses that for the population when they try to be abstinent from any treatment. We have high levels of depression and feelings of shame, low income, low education, lack of social support, and remembering, probably you may all know this, that 9 out of 10 of the pregnancies are unintended. We also found that drug use was a risk factor for poor parenting, and the perceptions of babies as high need when there's a new mom, hard to take care of. And so there's this maladaptive parenting. Next, Meghan. So the first big study that we did, Meghan and I together, was practicing safety mindfulness for mothers in drug treatment. And we came up with a 3-pronged approach, which was to help the pediatric office understand an asset-based approach of dealing with abuse and neglect. Meghan, yeah. And rather than a negative or child welfare involvement, building on strengths and building on prevention of abuse and neglect. So practicing safety is a national study that I did in conjunction with the American Academy of Pediatrics, where we tested it nationally, and I worked with them for about 8 years on that. So we implemented that in the pediatric clinic. We also developed an enhanced referral care management program with a social worker in the pediatric office and a care manager in the substance use treatment, who worked on helping the moms make appointments for pediatric care, get them to pediatric care, and then help them with all the referrals that came out of the pediatric visit. And lastly, we developed mindfulness-based parenting at MATER. And our aims of the project were to improve the parenting by decreasing stress, decreasing the children's exposure to ACEs, introducing mindfulness and intentional practice to the pediatricians and their staff. We really wanted to improve adherence to well-child visits, immunization schedules, and rates of developmental screening, and to, again, enhance the linkages and referrals and include the results of our work in the EMR so that physicians, pediatricians could see the mother's engagement. Next. Are you going to talk about this, Meghan?
Sure. So as Diane mentioned, mindfulness-based parenting was a novel intervention that was included in that study. And the first time that mindfulness-based parenting was tested in a substance use treatment setting. And knowing what we know about our moms who are in recovery, we know that they have a lot of judgment against themselves for their prior substance use and how it's impacting their current pregnancy or family life, children at home. They often lack a lot of compassion for themselves, and have difficulty regulating emotions. And so those were some of the core components that we built into the mindfulness-based parenting intervention. So actually the first 6 weeks of the program is geared towards compassion towards the mom learning how to be compassionate towards herself, trying to remove some of that judgment, noticing things about herself that are positive and trying to stay into the moment, to help with some of that emotion regulation as well. And then the last 6 weeks of the mindfulness-based parenting intervention is geared towards compassion towards the child and more of that dyad relationship. But we found that really working on mom's relationship with herself was key prior to working with the dyad itself. And so the 5 tenets of mindfulness-based parenting that are in our intervention are for mom to nurture herself as well as her child, so really taking care of yourself as well as your own children, to attuning to the child's emotional and physical needs, awareness of mom's own thoughts and feelings, and also that of her child. So really being attuned to the experience of the child, what the child's going through, their perspective, accepting herself, her child, and then the relationship between them. And then another thing that's said a lot through the mindfulness-based parenting curriculum is being able to respond wisely rather than impulsively, which is really a key component of mindfulness itself. And so one of the major outcomes of the study that we looked at was, does mindfulness-based parenting affect the parenting relationship between the mom and the child? And we used the Keys to Interactive Parenting Scale, which is an observational assessment where we would ask moms to come in with the index child, the child that we were going to measure and focus on. And we had a certain room, the mindfulness-based parenting room, where the moms would come in for their sessions that they were comfortable and familiar with. And we had a set of standard toys, and we would watch the dyad interact and play for 20 minutes. Moms were told they can just play how they normally would at home, even though they had somebody watching them. And then we used the KIPS assessment, which has 12 different items on it, used to measure the quality of parenting behavior. And so all of those 12 items, each one of them has behavioral anchors, and each ranking is between a 1 and a 5. So a 5 being the highest quality parenting behavior and the 1 being the lowest. And so there was the quantitative measure to the KIPS. So each one of those 12 items you would rate between 1 and 5, where you would get a total score, so a total quality of parenting behavior. And then there's also 3 different subscales of building relationships, promoting learning, and supporting confidence. Another great component of the KIPS tool is there's notes under each item where you can make observational notes, noting what the behavior was, what the interaction was between the mom and the child. And so we were actually able to use some of that data as well in a different paper, speaking more to how we saw mom, like the transition and more like the evolution of the improvement of that quality of parenting behavior from baseline to post-intervention. And so as you can see here in this graph, we saw significant improvements in the quality of parenting behavior in the total score, as well as all of the subscales. One thing that we did notice was women who had a significant ACE burden, like a high ACE burden, so that ACE burden meaning exposure to early childhood adversity and trauma, their high ACE score, they had to attend more sessions to get that greater improvement, whereas women who had a lower ACE score and maybe not attending as many sessions were still able to see some of that improvement. But one of the other things that demonstrated was that even women who had a significant ACE burden were able to see improvement with the intervention, meaning that it was trauma responsive. And actually the women who had the highest ACE burden in the study were the ones who saw the greatest change and the greatest rate of improvement over the course of the study. One of the other major outcomes that we looked at in the study was general stress. And to measure that, we used the perceived stress scale. All of our measures were done at baseline and then 2 to 4 weeks after the 12-week mindfulness-based parenting intervention. Women who had the highest baseline stress experienced the greatest change in total stress score. So kind of similar to that parenting assessment too. So women who really have this high burden coming in were able to see significant change after going through the mindfulness-based parenting intervention. And then again, another major outcome of the study, we looked at depression. Looking at pre and post with depression, we also saw a significant decrease in depression scores following the mindfulness-based parenting intervention. This had the greatest effect on those with moderate to severe depression. So as you can see with the depression and the stress and the parenting measures, we really saw some of that greatest change in those who had the heaviest trauma burden, the heaviest stress load, and the highest depression scores. And Diane, this is you.
And so one of the, just changing it from seeing the mother, when we first went in, Meghan and I, we weren't working at MATER, we were doing research with MATER, and we first came in and we were kind of astounded because we didn't understand substance use treatment in America and how punitive it was, and how there was always a sense when the woman walked through the door, even though she had involved herself in wanting to be stabilized off of opioids by bringing herself to the hospital, there was still a lot of negativity and a lot of worry about her and her pregnancy and her eventual parenting. And mindfulness really changed that up to be saying, looking at it with that, what I called before, John Kabat-Zinn's orthogonal shift, instead of seeing it as like somebody at high risk who needed to be watched carefully and who you were skeptical about whether or not she would make it or she would recover, we then switched it around to meet her with compassion. And one of the things we did was we created a mindfulness room, and moms this was their mindfulness parenting classroom, but it was also open to them on non-class days for them to come up and use it to sit and meditate. When they did the mindfulness, they did crafts, and you could see Meghan here along with our admin demonstrating for this picture, but typically it would be moms making glitter globes, and they would make glitter globes with different colors of glitter that would represent their emotions, their body, and their thoughts, and then shake the glitter jar, and as the glitter settled, they would feel that they could settle too. And they loved these jars. They made multiple ones for their kids, for themselves, for their mothers, for their diaper bag. There were lots of these glitter jars around. We celebrated big time. We did a big graduation lunch with them, and we really called them out for being courageous, and they actually did get a certificate for completing that they could use when they went to court if they were trying to be reunited with their children, or if there was an issue where the court was trying to take the children away, they would have evidence of having been certified through this program. Back to you, Meghan.
And so one of the unique things that we did going into this, just knowing that this was the first time that this type of an intervention was being implemented in a substance use treatment setting, we used the REAIM framework, which is a public health framework that's used to look at implementation and see, is this something that's generalizable? Is this something that can be implemented at different sites? And if so, how? How was this intervention really rolled out? Like so often, as you know, in research, you'll read a study and you'll see, and it's not really clear how they actually did it. So the nice thing about the REAIM model is it gives you a lot of that information. And so REAIM stands for reach, effectiveness, adoption, implementation, and then maintenance. And so one of the things we looked at with REACH was, did the women who participated in our study, how similar were they to the general clients at MATER? And we found the only significant difference was that women who participated in our study had more college experience. When we looked at effectiveness, we had a lot of that quantitative data that we shared before around the parenting and stress and depression, but we wanted to look more at, what were these changes? What did these changes look like in life for mom? And so we looked at all that qualitative data in the KIPS assessment that was in all of those observational notes. And some of those shifts that we saw between the baseline and the post-intervention was we saw that moms were more sensitive to their toddlers' cues, that they were more engaged in emotion sharing, like verbalization of sharing an emotion, like, oh, when they were talking to their child, saying things like, oh, you seem so happy. Even just verbalizing something like that can then name it for the child and mark a moment. And that was something that we really saw in that post-intervention after moms went through the mindfulness-based parenting program. We saw another thing was less control in play on the mother's part. So typically around baseline, mom would introduce a toy and then would keep, kind of directing the activity or what toy that the dyad was playing with. And what we saw post-intervention was moms really attuning to the child, trying to pick up on, does the child want to stay engaged in this activity? Should we stay in this activity? Or does the child look like they're ready to move on to something else? So that was a really big shift that we noticed just in that quality of parenting behavior. One of the biggest supports that we found in adopting this intervention was our multidisciplinary team. Diane can attest to, you name the person, we have them on our team. We had caseworkers, peer specialists, social workers, PhDs in public health, PhDs in psychology, we had pediatrician, we had just anyone, anyone and everyone was a part of the team. It was intentional though, and it really gave us a lot of different perspective on how to approach different things, and really led to a lot of the feasibility and the success of the project itself. Another one of the supports in implementing this project was Diane led a lot of the charge in making sure that project staff and clinic staff were trained in mindfulness-based stress reduction. So this wasn't just something that we were implementing, in the clinic as a research study and studying. It was something that a lot of us were living in our daily lives, and something that, is a core component of MATER today. And then maintenance. We have a lot of diffusion of mindfulness in the clinic today. A lot of the staff at MATER is trained in mindfulness-based stress reduction. In fact, in a few weeks, right, Diane, we are rolling out so we partner with Jefferson has a Meghan O'Brien Center for Integrative Medicine, and they're the mindfulness-based stress reduction course that a lot of our staff have gone through, and our women. And they are going to host a mindfulness-based stress reduction course just for MATER staff. So we have an amount of staff who still need to take it. So we're really excited about that. Another thing to mention here was Diane was able to work with the staff at Meghan O'Brien to create this scholarship. So women who went through our mindfulness-based parenting intervention twice were able to be scholarshiped into mindfulness-based stress reduction at the Meghan O'Brien Center for Integrative Medicine. And this was a big deal for our women who were able to do that. And I can't recall the total number of women who have gone through it, but it was probably close to 10 who did that. It was really great because it's something that they walk away from. You have a certificate, you have this training. And it was a way to bring more mindfulness into their daily living too. A follow-up to this, so we know that the intervention works, and now what we're working on, we have a manuscript in development that we are hoping to submit sometime in this next month is more the how. So how is mindfulness realized for this population? How are they using it in daily living, and what did it mean to them? And this piece is really important moving forward, because this will inform our next iteration of mindfulness-based parenting research. So looking at things like, what sticks, like what works, especially for busy moms who are engaged in treatment and have young kids and everything. Some of the things that we found out of that have been this intergenerational transmission of mindfulness practice. So as Diane mentioned, the glitter globe is really popular. Moms use it a lot. And what we've found in some of the sessions, moms would bring their children in. So out of the 12-week session, 3 of those weeks, moms bring their child in, and they have a mother-child dyad time where the mindfulness-based parenting teacher can kind of guide them in some mindful play and coach them and give them some feedback. And what we noticed from some of the teachers' notes was when some of the older children, like older toddlers and young children, would come in for that, they would see the glitter globes, because as Diane mentioned, they're like all over MATER. They would see them and point to them and say, we have that at home. That's on our table, and we use that at night. And in several cases, the child actually in that circle led like a little breath meditation with mom, sitting on the floor and practicing how they shake it and use it. So that was one of the things, is we see now the children are getting some of these mindfulness skills that they're able to use. And another thing that came out of this that we found is the effect of mindfulness-based parenting on recovery. A lot of women articulated that a lot of what they learned in mindfulness-based parenting was able to support them in some urges that they had or cravings, and that it really is supporting the recovery efforts.
So one of the other pieces I remember I mentioned was the pediatric work. So in the pediatric work that we were doing, the pediatricians wanted to collect data. So we looked at some surveys, and we asked mothers in the last 12 months about perceptions they had of their healthcare provider. And what we found was that at the most, 62% was the highest rating for the physician showed respect for what they had to say. And at the lower end, less than 30% of women said the physician asked about their viewpoint or opinion as a parent. So we noticed that there was this disconnect, and we wanted to see what could we do to improve this. Next. So we then asked we had other questions, which was to ask moms what aspects of the child's primary care do mothers who have OUD value. And what we found was that they really like when the doc remembers them, and that when they listen carefully, and when they support treatment. So this was an opposite. The moms had this value that when the physician noted to them or asked them, how are you doing in your substance use treatment? The moms saw it as positive. And we worked really hard to get the physicians to ask them about it, because the physician's perception was that they didn't want to embarrass mom or put mom on the spot and talk about such a sensitive issue. And that was a disconnect. Once the physicians learned that moms really did want them to check in with them, it changed the dynamic of the relationship, but only where there was that, we could only do it like one-on-one with getting one physician to do it. Another physician would say no. And the majority of physicians stayed in their own comfort zone. So as a result, you can go to the next one, Megan. As a result, we decided from that study that we did, why not do mindful-based pediatric centering? Why not really institute a group care model where there was mindfulness training, well-child visit, better adherence to that, and immunization, and using that practicing safety modules to improve anticipatory guidance, developmental assessment, referrals, and follow-up back to the physician. Enhanced emphasis on this developmental screening was huge, because we found in the practice that saw our women, they didn't do general developmental screening, universal developmental screening. So what we did was we worked with them, we had them trained in developmental screening, and we had it put into EPIC. And so it became a regular part of the practice. And also the practice saw that they had a financial hit for doing this. They actually, not hit, but they actually increased their billing over the month that they instituted this. And so they were motivated to continue to do it. Next. So what we did was, Vanessa Short, one of our other faculty members, wrote a grant to ARC for the group pediatric care with a pediatrician who I helped recruit from Ohio, from Cincinnati. And she and the pediatrician wrote this ARC grant for it's a 5-year grant, about $2 million. And the physician is at Nemours, because that's who runs our pediatric department, Nemours IA DuPont. And so their objective is to do group well care visits at MATER. So when the women come for their methadone in the morning, and then their therapy during the afternoon, we have child care centers located at the substance use treatment facility, and they'll go into the mindfulness room that I showed you before, and they'll do these group visits that are embedded within MATER, include mindfulness, and are clinically tailored to this population. Next, Megan. So 6 to 8 mothers will be in the group with similar aged infants. There'll be a 2-hour well care visit with the physician will be there, a nurse practitioner, an RN may be there, and an LPN may be there, it depends. There'll be food. We always, in our groups, we provide food, so they'll get breakfast, and they'll have health assessments. Immunizations will be done on the spot, developmental screenings, plus the maternal participation in infant care. So it's just like prenatal centering or centering pregnancy. The moms will weigh the babies like they would weigh themselves, and there'll be facilitated group discussions, interactive activities, and mindfulness will be led at each visit. And this is centering parenting is an evidence-based model of well child care. Next. So that grant is happening while this grant is happening too. Meghan and I are running our second big grant through, this one's from SAMHSA. This is FAMU. It's a transformational approach to residential treatment. So we have outpatient, we should have said that, we have about 250 women outpatient, and we have a residential program that can house up to 21 women and 3 children each. And this SAMHSA grant was for the residential treatment facility, and it was to bring families into care, because typically in drug treatment, as some of you may know, families are on the outside, and most of the people who are substance use providers sometimes see the family as a cause of the problem, or at least a participant in the problem. So this was transforming that and saying, no, families need to be included. So we began screening families for risk and offering them case management for a number of risks they may have: mental health, substance use, tobacco, anger, and we invited families to family dinners. Pre-COVID, we're getting ready to do them outside again this spring, but we had these family dinners weekly, and family could be whomever the woman says is in her family. It could be a best friend, a grandmother, a sponsor, a partner, a father of a baby, anyone she said, but she could invite two people every week. And then tailored mindfulness groups were designed, and those are for preventing child abuse and neglect or child ACEs, improving maternal treatment outcomes through family education, because some families, when we screen them, said that they saw treatment as a continuation of the drug using behavior, just another scam in the lives of these women. You know, families are frustrated. By the time the women come to us, they're in their 30s, they've been using for a while, and they have really dysfunctional relationships with their families. So bringing families in and educating them about how difficult the woman's life is as she goes through treatment, and to have them help them be supportive. And then engaging adolescents, partners, fathers, and extended family members in tailored mindfulness groups is the next part of this grant. We're also doing outreach to communities of color, because we know that nationally women of color are underserved. And so we work with Maternity Care Coalition in the city of Philadelphia, who has Moms Mobile Outreach, and they're going out with their mobile outreach, and they're actually going to communities that are underserved and bringing the MATER information to them and connecting them with us. So we actually have someone in our program who works inside our program from this agency to help bring women in, and then to follow women with home visitation that graduate or leave the residential treatment facility, however they leave, whether they graduate or whether they just, walk out of the program. The home visitation will be instituted and continued. And then part of this project supports the pediatric centering, and it also supports the centering prenatal care. That's also embedded at MATER. So this is this was the slide that we didn't mean to cause seizures at SAMHSA by having the reviewers look at this, but this was just to show you that we were going to be really transforming everything we did in order to do this grant and to change things, and that we were going with a guiding mission that included culturally adapting language and adapting care. That we were going to be now a family-centered approach rather than an individual or maternal child alone, and that we were going to be trauma-informed. You can go to the next one. So the elements of FAMU are the mindfulness-based parenting, and I think, I went through all of these. You can go to the next slide, Meghan. Is that you or me, Meghan? Are you going to talk about the DEMS?
Yeah, I can go with this real quick. Maybe in the interest of time, I will just kind of fly through these next few ones here. So as Diane mentioned, most of our women are around 32 years of age, half enter treatment. This is the demographics for our SAMHSA grant. Half are white, a quarter are Black, and a quarter identify as other. And most come in with an average of three children. And then I'm just going to go through, just so we have time if anybody has any questions. We do have a doula study at MATER where we're looking at the effect of doula engagement on maternal-child health outcomes, as well as healthcare utilization and recovery. This pilot study is currently underway. We have about 35 out of 50 women recruited into the study, And we are currently looking at the preliminary interview findings, which have shown a very positive experience of women with their doulas. They've assisted them with things like family reunification, health advocacy around having a labor and birth plan, helping them with some physical resources as well as recovery support. We have an RO3 to ARC that we are on this doula work that we're resubmitting in October of 2021. We have a lot of collaboration with the Philadelphia Department of Public Health's doula program, where we're now working really closely with them on this study. And we're also doing work with our community health workers. We have a HRSA submission to the Maternal-Child Bureau of Health that we will be submitting this week to support a maternal-child health module in our CHW program at MATER. And lastly, we have a study where we're collaborating with Jefferson's College of Nursing to look at the experience when women come into treatment through the emergency department and then they're stabilized at our hospital and coming into that acute induction period. We're looking at the experience of nursing as well as the experience of our patients that go through that eventually would inform a training that would be led by MATER, co-developed with Jefferson College of Nursing to provide specialized training for nurses in substance use treatment. Diane?
Yeah, we're going to skip this. We have a new grant. We're going to be doing stimulant use treatment, but we'll talk about that another time. Okay, can go. And we have something called Dad's Lab, which is for partners, and it's a partner group, and we're just starting it off. We're having a hard time kicking this off and getting dads to be part of this, but we're trying yet another iteration to see if we can do it. Next. We talked a lot about mindfulness, and I think it's important to understand that it's what happened to us is we became more compassionate versus empathetic. And if anyone has questions, I'll answer them about that. Trauma responsive, and also this really helped us with implicit bias and looking at implicit bias and how we treat women of color and look at what we do with women of color. And we did a study, and it was really disappointing how physicians give different levels of methadone to women of color versus white women, even with a protocol. That paper is in the process of being published right now. We also looked at structural racism at MATER and realized, and that's Meghan mentioned our community health program. Well, what we did was we came up with a community health worker program for all of our lowest paid employees, that were the majority of them are Black, and then with them becoming CHWs and us changing their titles, they'll be able to get a significant increase in their wages and also be more therapeutically involved with patients. And lastly, it's mindful dialogue, and you can go the next one, Meghan. Mindful dialogue is about what the staff does and the leadership. So we meet weekly over COVID to really process all of the difficulties and the stress and the worry about our patients all being virtual. And we meet together on Friday and we do a meditation together, we read a poem, and then we go out into breakout groups and just discuss things about home life, work life, partner life, whatever's coming up for us, sharing it openly and celebrating with each other the joy in our lives as well. Go to the next. Our themes, Meghan and Dr. Short, another professor analyze the themes that were on the last slide, but you'll have these slides to look at. And we were lucky enough to get a commentary about the use of mindfulness dialogue in staff during COVID and how it helped us. So I'm not going to go through final thoughts. I'm going to stop right there with the idea that if there are questions and if people would like us to stay for a few minutes, we can definitely stay. We really appreciate this. We went through it. We